afternoon, everyone. My topic is about a subperiosteal unilateral cleft lip repair and vomerine flap. Cleft lip, as we know, it is the second most common congenital anomaly in pediatrics. It is a work of multidisciplinary cleft care, including audiologist, dentist, oral surgeon, otolaryngologist, plastic surgeon, and recently we have a speech pathologist. So it is a teamwork, and in our hospital we have a very nice teamwork. I would like to thank them from this seminar. First, this is our resident, and Dr. Rajwan is a newly graduated plastic surgeon, Dr. Saman and Dr. Shoch. We have also not to forget the role of our anesthesiologist, Dr. Ahmed and Dr. Haveen. Also our scrubbing nurses, our assistant anesthesiologist, and all who are working in the hospital, in the operation theater, even the cleaner. Without the clean theater, we don't have a suitable place to work. Moving to the detail, it is treating the cleft lip or the cleft surgery is a teamwork, and it is a multiple stage. So it is important to inform the parents of the pediatric or the child that it is a multiple surgical intervention starting from infancy to the adulthood. The goal of the surgery is to make a normal appearance at the conversational distance. It is naming the cleft lip as a cleft only, it is a misnomer because nose is always included in the cleft surgery. So cleft lip without exception must involve correction of the nasal deformity. I'll make a rapid review of the nasal deformity. And those patients with a cleft lip, they have a short medial crest on the cleft side with a long lateral crest. This is a false appearance because the total length of the lower lateral cartilage are the same. They have a caudally displaced dome or hooding. The dome is flat and displaced laterally. The columella is short on the cleft side and based to the non-cleft side. They have a nostril horizontal orientation. The ala is displayed laterally, inferiorly, and posteriorly. And usually there is no floor of the nose. The septum is deflected caudally to the non-cleft side while it is deviated posteriorly to the cleft side. This photo demonstrates the septal deviation in case of cleft lip and palate. The nasal deformity is based on the degree of hypoplasia and collapse of the maxillary bone. That's why we are using this technique in the subperiosteal plane. The maxilla of the cleft patient, as we can see in this photo, the lesser segment is displaced and hypoplastic in comparison to the normal side. In the CT scan, we can see it is hypoplastic and collapse. That's why the ala base has not any adequate osseous support. Our technique is marking is the same as modified Miller technique. We have no M flap or L flap, both are excised. This is the marking. We have a small triangular flap on the cleft side and a small inset for the triangular flap on the right side with a very small C flap which form the nasal sill partly, and it will simulate the medial foot plate at the reconstructive time. Starting first with the vomerine flap, we are using an operative microscope, using a modified dot kill and mouth gag. This is the upside down view. The palatal mucosa is somewhat pale while the vomerine flap is pinkish. The markings start along the vomerine crust toward the skull base at the junction of the oral mucoperiosteum and vomerine, extend and to be continued with the premaxilla and the C flap, while on the lesser segment the marking is at the junction between the oral and the nasal mucoperiosteal junction, extending into the incision along the cleft. Now the incision is done along the vomerine crest. This landmark is very important. It is at the junction between the oral mucoperiosteum and the vomerine mucosa. There is always an inferior, the marking is inferior to a groove in the vomer which is uniformly present in case of complete cleft. Now, using a 69 angle beaver blade, the incision is extended around the side of the premaxilla and continues with the lateral incision or the C-flap of the lip. The vomerine flap is dissected or elevated anteriorly in the subpericondylar plane, while posteriorly it is a subperiosteal. Now we are moving to the lesser segment, which is the incision is made using a 69 angle beaver blade at the cleft margin between the oral and the nasal layer, using a dental scala to elevate about 3 to 4 mm laterally. And after that, we are making just leaving a few millimeters above the sulcus. We are making the incision down to the periosteum, and the incision around the piriform aperture here shown in this circle. Now the periosteum, the dissection plane, this subperiosteal plane, is dissected up to the level of the infraorbital foramen, taking care not to damage these structures. And after that, we are making an elevation around the piriform aperture to be continued with the other plane. Now, this step is very important. We have to divide both the lateral nasal wall and the nasal floor with or without inferior tibia based on the tension. As shown in this circle. Here, the level of our lateral nasal wall division is just 1 cm behind the aperture, piriform aperture. Now, this is the inferior turbinate, which is cut in the circle, and we can use a dental scala to remove the bone inside the inferior turbinate that can be used later on to re-augment the alar base. Now we move to the further dissection of the periosteum. This dissection is very important. Laterally, we make a vertical incision just only the periosteum, and horizontally just below the inferior orbital nerve down to the nasal cavity. It is done just before the vomerine flap inset, and moving to the vomerine flap inset. It is an overlap technique. We can use to the nasal floor, but especially to the oral layer, give more strength to the repair. After that, hemostasis is very important, especially at the back of the vomerine flap. Now, anterior vomerine flap is elevated in the subpericondylar plane using a knife just to enter into the cartilaginous septum is exposed here. The vomerine flap closure, it is anterior to the alveolus, is to the lateral nasal wall, while posterior it is under the oral mucoperiosteal flap. This is the final closure of the flap. This figure demonstrates how it is overlapping the vomerine flap into the mucoperiosteal layer. Now the non-cleft side muscle is dissected, and the upper or the superior part of the orbicularis is divided. The nasal ada is dissected on the cleft side and non-cleft side, and the cleft side muscle is dissected as well. The orbicularis is detached from the alar base, and the lower lateral cartilage is dissected. The alar is repositioned, and this is the bone graft that we took from the inferior turbinate, placing at the alar base to encourage new bone formation. Now moving to the nasal floor closure, it is a three-way stitch, must be watertight because it has a risk of a fistula, common site for fistula formation. The alar base now is sutured near to the C-flap, starting to the mucosal closure. The lateral mucosa should be approximated over the premaxilla, because the downward traction of the wound will pull down the mucosa downward. Now the alar base stitch is placed using a foam or nylon. It is sutured to the superior aspect of the orbicularis fibers, not to the anterior nasal spine. And we continue mucosal closure by adequate alignment to distribute the length between the medial and the lateral part. The muscle is repaired. It is important to overlap the lateral fibers over the medial fibers. Above and below stitch is placed and continues suturing in between. and the skin is sutured using an angled suture at every tip of the flap, and the skin is closed using an 8-0 Ethion. Lastly, the vermilion closure using a Z-plasty here. This will, to avoid a straight line scar and to align a wet-dry injection in a proper position. The dolma suture is applied here using a blue needle, using a 5-0 PDS to lift up any web and rim. Postoperatively, taking out the pack, check for active bleeding. You can use antibiotic, analgesic, but most importantly is tranexamic acid 10 mg per kg, because there is a risk of bleeding. Advantage of subperiosteal dissection is it is a more natural plane, enhances the osteogenic activity of the periosteum, thus it will have a better ALS support, good supplement of the overlying muscle, tension-free closure in the white cleft, and it does not affect the facial growth. The vomerine flap downside is the oozing, both intra and postoperatively. That's why we have to prescribe tranexamic acid postoperatively. Advantage of vomerine flap, there are several advantages, including single layer closure of the hard palate, and it will decrease the Langenbach lateral incision in the subsequent repair of the cleft palate. Key point is very important. Every suture is important in cleft surgery. Always overcorrect every structure, especially the the nose, and tension-free closure. I'd like to share with you some cases. This 3-month-old child with the incomplete left side cleft lip with the moderate nasal deformity. This is 1 week postoperatively. Another patient with the incomplete cleft lip on the left side with the moderate nasal deformity, 1 week postoperatively. You can see the adequate alar-based support. Moving to more difficult cases. This is a patient with the very severe left-sided cleft lip deformity with a severe nasal deformity. This is 4 months postoperatively. And last case is the right side complete cleft lip with a severe nasal deformity, 1 week postoperatively. Thank you very much.
Thank you very much, Dr. Diar, for this nice presentation. So we at the end of this session, and we go for a break of 15 minutes, and then we come back for the last session after 15 minutes.